My name is Shaji Kumar. I'm a consultant in hematology at Mayo Clinic in Rochester. The field of smoldering multiple myeloma has evolved considerably over the past decade. First, with the revision of the diagnostic criteria for myeloma, which moved the patients with ultra high risk smoldering myeloma into the active myeloma category by virtue of the presence of various biomarkers like plasma cell percentage in the bone marrow, 60% or more, free light chain ratio. That is more than 100, and presence of 2 or more MRI lesions. As a result of that, the natural history of patients with smoldering myeloma, excluding those patients, had to be redefined. And in addition, we have also learned quite a bit more about the biology underlying the progression from smoldering multiple myeloma to active myeloma. As a result of these changes, we undertook a large International Myeloma Working Group study that examined the risk factors for progression of smoldering multiple myeloma to active myeloma. What we found in that large study was that the same three factors that we have used in the past for developing risk stratification for patients with smoldering myeloma still held true, though we had to use different cutoffs. So when we used a 20% or higher cutoff of the bone marrow plasma cells, a free light chain ratio cutoff of 20, and a M spike level that's more than 2 gram per deciliter, 2 gram per liter, we were able to identify patients with varying risk of progression to active myeloma. So for those patients who had 2 or 3 of these risk factors, the risk of progression at 2 years from diagnosis of smoldering myeloma was almost 50%, suggesting that this might be a group of patients that where a intervention could be justified. And in fact, when this criteria was applied to the most recently completed phase 3 trial looking at lenalidomide versus observation, most of the benefit from intervention, in fact, came from this high risk group, suggesting that this risk stratification is something that is clinically relevant. Obviously, smoldering myeloma, the risk changes over time. We know that for the first 5 years, the risk remains fairly constant at about 8 to 10% per year. Beyond that, it comes down to about 2 to 3% per year for the subsequent 5 years. And beyond 10 years, risk of progression from active smoldering myeloma to active myeloma gets down to 1% per year, similar to what we saw with monoclonal gammopathy of undetermined significance. So the field is continuing to evolve both in terms of identifying characteristics that will allow us to, again, tell which patients are most likely to progress and hence might be candidate for clinical trials for early intervention, or if sufficiently high enough risk, maybe even for intervention based on the phase 3 trial data that we already have. Now, in addition to this, there are two other aspects that are currently going through evaluation. One of them is to look at the genetic abnormalities. We already saw in our data set with the IMWG study that we can also incorporate fish abnormalities into the risk stratification system. In fact, when you develop a slightly more complicated system that incorporates the fish findings as well as the entire spectrum of the bone marrow plasma cell percentage, the free light chain ratio, and the M spike level, we can actually develop a scoring system with scores up to 12, which identify or divide these patients into 4 groups, with the top group having a risk almost up to over 70% at 2 years, suggesting that some of these patients may even be considered as having symptomatic disease. So that risk stratification systems continue to evolve. The other part that the current system does not take into account is what happens to these numbers over the follow-up. So if somebody did not meet high risk but were high risk a year after diagnosis, where does it place them? So we are continuing to study those evolving parameters to get a better sense of how we need to follow these patients up and what do we need to do with the numbers that we get from these tests. In parallel, we are learning a lot more about the biology. There's detailed studies going on looking not only at the tumor characteristics in terms of the mutations and so forth, but also looking at the bone marrow microenvironment, particularly the immune microenvironment, to get a better sense of what drives progression in some patients, whereas others remain progression free. Other technology, especially single cell technologies, are being employed to get a sense of, what are the characteristics of the truly malignant cell versus the plasma cell that might be clonal but doesn't have the malignant characteristics, to get a better individualized assessment of the risk of progression. So certainly much progress has been made. We know that some of the high-risk patients benefit from early intervention. We still continue to define what should be the ideal intervention. Should we be treating some of these patients like myeloma? If we treat them really aggressively, can we cure some of these patients? So those are all important questions which hopefully will be answered in the coming years.